So we're going to cover trauma hot off the press. This is trauma from the last 3 years or so. And it's a total potpourri ranging from cutting edge things, some things that we may never do, some things that haven't panned out, and some things that have become part of our practice. So let's talk about trauma care hot off the press. We're going to start with head trauma, if there's anything new that's happened in head trauma. And we're going to cover TXA, hypothermia, but we're also going to cover optimized prehospital care. There have been some articles that have looked at, one in particular that came, the EPIC study that came out of Arizona, that's looked at optimizing prehospital care. And what they really wanted to do is focus on this study. It's a big study. It's a before and after study of 15,000 patients before and more than 6,000 patients after, looking at moderate to severe traumatic brain injury and then optimizing prehospital care. And in particular, things that make a lot of sense. Things like avoiding and treating hypoxia, avoiding and treating hypotension, and preventing or correcting hyperventilating. So you don't want to over hyperventilate somebody. So you want to basically make their ventilating optimal. So what they did in this, they did a primary outcome of survival to hospital discharge. That was their main primary outcome. But they did have some pre-planned secondary outcomes. We know that basically data dredging and going into studies and kind of finding subsets later doesn't count. But they did this as a pre-planned thing, looked at pre-planned secondary outcomes like survival to admission. They looked at subgroups, including severe or severe intubated patients with head injury. And what they found overall is that their primary outcome, even when they optimized hypoxemia in the pre-hospital setting, so avoiding it and treating it, avoiding and treating hypotension in the pre-hospital setting, and then preventing and correcting hyperventilation in the pre-hospital setting, what they found is that the primary outcome, there was no significant change. So the primary outcome of survival to hospital discharge, no significant change. But in this pre-planned subgroup analysis, they found that at least in severe traumatic brain injured patients or severe traumatic intubated brain injured patients, there was a slightly improved outcome. And they conclude in this particular study that you could improve outcomes in those two groups. What I think is it's important to optimize care in general. And I think it's nice to study these patient-oriented outcomes to see if it makes a difference. But optimizing what we do in the pre-hospital setting, I think almost in any situation, is a valuable thing. And this paper basically said, at least in the really severely injured patients, it's something to consider doing. So, and I think it's just a good practice in general. So that's kind of just general care. But what about TXA? So TXA, we know, is basically an antifibrinolytic. It's a drug that basically stabilizes clots. It doesn't make you bleed more. It just makes you stabilize the clots that you have. And we know in the CRASH-2 trial, which was a gigantic trial done many years ago now, that was over 20,000 traumatized patients, they found that when they gave TXA with a number needed to treat of about 67, it decreased all-cause mortality. So it helped. Basically, people survived more. It was not a gigantic impact, but it had some impact, and it led to some people using it routinely, some people using it intermittently. But TXA looked like it had a little bit of an impact, a little bit of a decreased mortality. And when they looked sort of kind of poking through all the data that came out of the CRASH-2 trial, they found that maybe head injured patients might have some benefit, which led then to the CRASH-3 study, which was a big study that came out last year and got a whole lot of press last year. A lot of people kind of weighed in on this. There were a lot of podcasts on this and looking at the CRASH-3 trial. This was a big study. It was 13,000 patients. So it was multi-center randomized controlled trial, all with traumatic brain injury that was significant. They had to have a GCS of 12 or less, and on head CT scan had to have any intracranial hemorrhage. So they had to have basically evidence of CT positive and a GCS of less than or equal to 12. What they found, again, 12,737 patients, actually a gigantic study, and it was TXA versus placebo. Now, they ended up with basically that's the number they ended up with at the end of the study. But what they did a couple things in this study that ended up problematic. I will cut to the chase for a second. What they did initially is they had an initial primary outcome of all-cause mortality. And it turned out that that was not particularly helpful. They changed it to head injury, basically. So they wanted to, so it's like, no, we're not going to look at all-cause mortality. We're just going to pull out the head injured patients. And what they found initially was that there wasn't much change in outcome, which was kind of unfortunate. It was this gigantic study. It was kind of unfortunate. So what they ended up doing is they did some cheating things. A couple things they did. They went back and they kind of filtered out and only looked at patients that had had the TXA for in a 3-hour window. Initially it had been 8. They dropped that to 3 because we know that 3 hours seems to be the window where TXA has its effect, so within 3 hours of injury. So they started to subset then. They also changed the study mid-study and used the 3-hour window kind of ongoingly in the study, so it kind of fiddled with the study design, which is a no-no. So that's one of the things that they did. And then they also decided, because they didn't really find a significant impact, they took out of the study people with a GCS of 3 or people who had non-reactive pupils. So they took out the severe head injured patients. So they're already fiddling with a study during a study, which is just a no-no to do. But when they did do that, they were able to find a little bit of improvement. What they found is if you had a GCS of 9 to 15, in this post hoc subgroup analysis, no, and no, they found a significant impact. The number needed to treat of 59. This particular study has come under a lot of heat and a lot of people in scrutinizing this. It's unfortunate. It's a gigantic study. If it had been done kind of cleanly from the beginning, we might have some clear answers. We really don't with this, and I think a lot of people have not adopted using TXA routinely for head injured patients in that sort of mild to moderate group. Certainly not for the severe head injured group. It didn't seem to help them. So TXA has not been kind of the be-all, end-all for people with traumatic brain injury, and that's kind of unfortunate. And this study is messy, which is also highly unfortunate. But this is not something that's been adopted routinely. And we do know that head injury is really devastating. We would like to find something that improves the outcomes from people with head injury. Is hypothermia something we can do? Now, there's a study called the POLAR study. You have to love how they name these things. And what they did in the POLAR study is they took people with severe traumatic brain injury, so a GCS of less than 9, and either actual or imminent endotracheal intubation. So people really sick, bad injuries that were going to get intubated. And they basically randomized them to hypothermia or usual care. So they either got cooled or they got usual care. And it was 500 people in this study, big randomized study. And they wanted them all addressed within about an hour, 1.8 hours of the injury. They wanted the intervention to at least start within 1.8 hours of the injury. Now, like everything hypothermia, we know this from people that we do, quote, therapeutic or targeted hypothermia with, and who are arrest patients. They couldn't really get people hypothermic for about 10 hours. So it took a while to get them there. They did, though, if they got them there, maintained them there for 3 to 7 days. And what they found in this is that there was no change in outcome. There was no 6-month change in outcomes or mortality. So it really didn't support using this prophylactically, hypothermia in patients. Their outcomes, that mortality was still high in both groups. So this did not turn out to be the panacea. So we're still left, as far as right now in 2020, with traumatic brain injury, with no real magic answers to fixing patients who have traumatic brain injury. TXA doesn't seem to work even in the sort of mild to moderate cases. Therapeutic hypothermia, this hypothermia concept doesn't seem to really improve outcomes either. And maybe if we do good pre-hospital resuscitation care and focus on hypoxia and watching the blood pressure and watching the sort of hypercarbia issue, we can help patients a little bit, but the reality is there's no magic answer. The main thing is just don't get head injured because people don't do very well. So that's head injury. Let's take another topic. What about blood? We don't want to overuse our blood supply, and we want to use it optimally in our blood supply. So in trauma patients in general, this is not head injury, this is just trauma patients in general, is using fresh blood better than using older blood? Now, to be honest, I hadn't really thought about this question much in the past. I always trusted our blood bank people that are really good at what they do to know what they do, and anything that's in that cooler over there is something that's good to use and fine to use. This is basically called the transfuse study, again, another clever name, that looks at whether the age of transfused cells and it has any change in outcome. Now, this is basically a gigantic sort of literature search, systematic review. And what they found in this, 42,000 subjects in this, 22 randomized trial looking at older versus younger blood. And they basically found that there's no change in death rates if you transfuse older blood than you do younger blood, so for fresher blood. So the reality is it's probably fine. And so just trust anything you're pulling out of your cooler over there. If you need to transfuse a trauma patient, it's not going to change their outcome. Now, vasopressors. Vasopressors are something we don't usually use in trauma, right? We basically usually fill up the tank. They're bleeding, they're traumatized, they need the tank filled either because it's neurogenic shock because from spinal injury, or they're bleeding and we just need to replace what they're bleeding. But I wonder if that's really something that's true. And there's a little bit of research going on now in the use of Arginine Vasopressin. So Arginine Vasopressin in trauma patients, if you see somebody who's a trauma patient, you can measure a deficiency in that in trauma patients. And we know that having it around improves platelet function. It's part of how platelets work, this Arginine Vasopressin. And we know that it can have some hemodynamic effect. Not a huge amount, but some hemodynamic effect. Would this help in trauma? Can we use this in a trauma patient? So this particular study, this small study, this one that's abstract number 5 in this particular chapter, looks at using arginine vasopressin in a pilot type study. So this is not meant to decide anything except should we study this further. And they did a very interesting study design. They basically, most of the patients were penetrating trauma, 79% were. It's 100 patients, not a huge study. Again, it's a pilot study. They looked at patients that already got greater than 6 units or greater of some sort of blood product. And what they did at that point, and their goal here was to minimize the use of blood products. They didn't really look at outcomes. They said, will this decrease our use of blood products in these folks? They randomized them to using arginine vasopressin, a bolus or a bolus of 0.04 units per minute of infusion, compared that to placebo. And then again, their primary outcome was what happens to using blood products. And they found there was a significant impact. Use less blood products if you were using the arginine vasopressin, 1.4 units of blood products compared to almost 3 in the group that didn't get arginine vasopressin. So it is kind of an interesting idea of, at least if your goal is to minimize the use of blood products, maybe arginine vasopressin is a good thing to do. They did look at a few other sort of other outcomes at this to see. They found that basically there was no change in crystalloid use, no change in vasopressor use, no change in mortality, which is something that's actually really important, and no change in total complications. They did find less DVTs in this group. So all this study basically said was, we may be able to use less blood products, we may decrease DVTs, we may not have any other impact, and this is only a pilot study. So this is something that, just to keep your ear to the ground, this is something that may be coming down the pike, but just know that arginine vasopressin may be something that in the future we might use in trauma patients. So an interesting concept, using a vasopressor in trauma patients. All right, that's the sort of first 3 questions, but what about hypotensive resuscitation? So we know that we try to fill the tank in somebody who has had trauma, and one of the questions that comes up is, how high does the blood pressure need to be? How high do we need to go on this? So this looks at the concept of hypotensive resuscitation, getting them up to a perfusion level high enough to perfuse the end organs that we care about, but not necessarily go overboard and increase the risk of bleeding. What's interesting is that this hasn't been super well studied. The concept makes sense. It hasn't been super well studied, but there is a systematic review out there. It's abstract number 6 that looks at this. So basically it's a systematic review of the studies that have been done on hypotensive resuscitation. It's a total of 24 studies. It is a total of 3,000 patients, and it's 20 randomized controlled trials. It's interesting with the number of trauma patients that we all see in the world, that's only the amount of study data we have, but that's what we have. Pretty decent overall, not terrible. And what they found is that blood pressure goals of 70 to 80, so systolic of 70 to 80, again, goal is perfuse your brain, perfuse your kidneys, perfuse your heart, perfuse all the things that are important. Is that good enough? What happens to outcomes? What they found is that you just resuscitated somebody to that, not to normotension, but to the sort of this perfusing the organs systolic blood pressure. What they found is that there was a 50% decrease in mortality. 50% decrease in mortality. That is a patient-oriented outcome that makes a big difference. You die or you don't. You have half the chance of dying. If when you initially get resuscitated, you get resuscitated to this organ perfusion systolic of sort of 80-ish level. They found less ARDS. They found less total body organ dysfunction, which they perfused things, that was fine. There was no change in AKI, interestingly, but otherwise everything else was fine. And it turns out that overall this is a good practice, and I think a lot of institutions, trauma institutions and non-trauma institutions, do this anyway, but I think it's probably a best practice at this point to go to permissive hypotension, to allow people to be sitting at sort of 80 systolic. So that turns out to be a pretty good practice. Now, if you do need to resuscitate somebody who is a trauma patient, what should you resuscitate with? So I did a trauma case about 6 months ago, and our trauma surgeon, who's relatively new to our department, came in and said, the patient's coming in, he's hypotensive, has had a traumatic injury, get plasma hanging. Thinking, plasma? Why would he do that? Well, he based that on a couple of studies that came out in 2018 and 2019. 2018, both of them actually. There are 2 studies, and what's interesting is they come to different conclusions, and it tells you some of the problems with pre-hospital research. So these are both pre-hospital studies looking at the use of plasma in patients who were significantly injured and having hypotension as a result. So the first one, abstract number 7, is a Sperry study from 2018, and this is basically a multi-center, pretty big trial, and it was an aeromedical system, which means you're transporting a distance, or you're transporting from one hospital to another. So keep in mind that that's the milieu that they put this setting in. And what they did is they gave in the chopper 2 units of plasma as the group that they were intervening, and the control group basically got usual care. No plasma, standard care without. And it was 500 patients, pretty significant group. And to get included in the study, to even be entered in the study, you had to have hypotension and tachycardia that was felt to be secondary to hemorrhage. So you had to have a trauma that was causing some sort of physiologic response because you were hypovolemic. And 78% of patients were being transported from a scene, in again, aeromedical transportation, and about 22% were being transferred from one outside hospital to a trauma center. And what they found by giving plasma is that the mortality rate decreased significantly. It was basically 23% of people died if they got plasma, and 33% of people died if they got usual care, with a number needed to treat of 10. That sounds pretty darn good. They found no safety or adverse effect problems, and they said, wow, this rocks. This is better than sliced bread. This is a great thing. We should be doing this. It's always nice to get another study. So abstract number 8 is a smaller study. This is actually an urban study that was done in the Denver area. And what they did in this particular study, it's a randomized controlled trial, almost exactly the same design as the other one. These are patients that basically got 2 units of plasma versus standard care with no plasma. It was a study of 144 patients, had originally been intended to be 150, but it was only 144. I'll tell you why in a second. And what they did here is, and it's same, again, you had to be hypotensive, you had to be tachycardic, all felt to be due to hemorrhage. They looked at 28-day mortality, so also a mortality endpoint, another one we care about. And they found that actually the plasma mortality rate was higher, that it was 15% in the plasma group and 10% in the standard care group. And they also found no safety or adverse effects, but they just didn't find that same jazzy number needed to treat of 10 in that aeromedical group. Now, it's a little bit of apples and oranges, right? Transporting somebody from a scene in a helicopter or from another hospital who they're already starting to get resuscitated in a helicopter isn't necessarily the same as a very urban, short transport time, ground transport kind of group. And they do acknowledge that in the second paper. They basically say maybe this is something that if it's a longer transport time or coming from somewhere rural, this makes better sense. I think the jury is out on this. We don't really have clear data. And again, it kind of points out some of the problems with pre-hospital care, pre-hospital research, because it sometimes is apples and oranges. But keep your ear to the ground. This might be something that we're doing in the future, especially with long transport times. Now let's get to airway management and trauma. And we're going to talk about one of my favorite things in the world, which is the Bougie. So this next abstract, number 9, is a pretty huge study looking at the use of Bougie as a basically best practice, a first pass, use it in the first, as part of your first pass attempt in patients that could come in and need to be intubated. Now, this wasn't just trauma patients. This was all kinds of patients. It was 757 patients, so a lot, who needed endotracheal intubation in the emergency department. 17% of them were trauma. So it was a proportion of them, so about 150, 200 people-ish, that were trauma patients, and they just looked at first pass success rates. So they basically looked at what was your first pass success rate, and with the Bougie, it was better on the first attempt. You had less hypoxia on the first attempt. You were faster if you used the Bougie. And in the immobilized patients, it seemed to make things a little bit easier. This is, again, first pass attempt success rates. This didn't look at mortality data, so they didn't look at endpoints like that. But one could extrapolate that if you intubate them first pass and quickly, you have at least a better shot at an improved outcome. They didn't look at that, though. So just know that your likelihood of getting a first pass attempt that's successful, if you use a Bougie as part of your best practice first attempt thing, it improves it, and pretty significantly actually in the groups. So know that that's something to consider as a best practice option. And in trauma patients, because they're relatively immobilized, often in a cervical collar, or at least you don't want to move their neck, that's a nice option to consider. So pretty nice. Now the next question they address in this particular article is something that I was taught back when I trained a bajillion years ago, which was older people who have multiple rib fractures need to be in the hospital. And they need to be in the hospital because they get pneumonia and they don't breathe very well and they're just at risk for all kinds of bad things. And this paper actually says, wait a minute, not so fast. Let's see if that's really true. So this is a paper that basically is a chart review. Now you have to be aware of chart reviews. That you don't know exactly why people were admitted and you don't know exactly why people decided what they did. This is just looking at what actually happened, but you don't know why things actually happened. But this is a chart review of 330 elderly fall patients. So these are ground level fall patients, all older. 82% of them got admitted. What they did is they looked at these patients that got admitted and they looked at who had rib fractures and who didn't. So what they did within this group of admitted older people with ground level falls is they said, here's the group that had rib fractures. Here's the group that didn't have rib fractures. Did having rib fractures make a difference? And the rib fractures were diagnosed mainly on CT in most of these patients, not all of them, but most of them. And what they found is that whether you had rib fractures or not, it didn't, if you had them, it didn't increase your median length of stay, it didn't change your ICU length of stay, it didn't change your mortality, it didn't change what interventions you had, it just was another diagnosis on your list of diagnoses. So it implies that admitting strictly for those rib fractures may not be useful. If you're admitting for something else, perhaps there's a reason to be there. And honestly, they didn't even look into, this is the downside of a chart review, they didn't even look into why the patients were actually admitted. Was it a social situation? Was it because they had a hip fracture? They didn't really parse that out, but it looks like adding rib fractures to another, as another reason to admit, and it turns out in a significant proportion of these people, it was the only reason they were admitted. That may not be a good reason to admit them. So just keep that in mind. I'm not sure it would hugely change my practice, except I don't admit everybody with multiple rib fractures who's older. If they have a great home situation, if they're active, if they have someone who can watch them, if that's their sole injury, that's not necessarily something you have to bring them in for anymore. Now, ultrasound has become a gigantic part of trauma. And when ultrasound kind of hit the news about 15 years ago in trauma, we were all excited. We could use this ultrasound machine, that we could look and see if there's free fluid, and literature from Europe looked like that was a really sensitive way of saying this person's bleeding in their belly, and we can send them to the operating room. We don't need to image them, otherwise that's good to go. And it led to a lot of enthusiasm about using the fast ultrasound, which is now the EFAST, extended fast ultrasound in trauma, looking for things like pneumothoraces and looking for intra-abdominal bleeding and volume status and those, pericardial fluid, the kinds of things that we look for when we do ultrasound in trauma. This article I like because it looks at whether that enthusiasm is warranted. What has happened now in the 15 plus years that we've been doing ultrasound for trauma? What has happened here? Well, this is a 2019 paper, and it's a current systematic review of the literature and what actually happens. And this is, I think, fascinating. Always, question what we do. And this is something we're all really enthusiastic about. Does it really make a difference? So this is 75 studies done from 1989 to 2017, which shows you the enthusiasm we've all had for ultrasound. This is a lot of the long time period and a lot of studies. So 75 studies, 24,350 patients. So they glommed them all together and they looked at what does EFAST really get us? What does it actually do? Initially, it would have been FAST and then EFAST in the more recent studies. And they found, just to summarize, for things like pneumothorax, pericardial effusion, intra-abdominal free fluid, adult hypotensive patient volume status, adult normotensive volume status, and pediatric assessment, they found that the specificity is good. So if I see that you have free fluid in your belly, you have free fluid in your belly, and in trauma, it's probably something that's bleeding. But the sensitivity was not so much. The sensitivity on the good end, the best sensitivity was for pericardial effusion, which I think is kind of interesting because I'm not sure I buy that just on clinical experience. It's sometimes hard to see. But basically, this is a 91% sensitive for that. But overall, the sensitivities were in the sort of low 70s, high 60s for actually picking up the true injuries. If you see it, it's there. If you don't see it, it doesn't mean it isn't there. And so basically, it's fine for ruling in. It's not fine for ruling out. And the other thing about ruling in, so say there's some free fluid in the belly. Is it from the spleen? And is it the spleen injury something that we're going to just watch or something that needs an operation? We're doing more and more observation. So it turns out that maybe EFAST is something that we're not using as much. And at our institution, there's a big sticker on our ultrasound machine in our trauma base that says, no ultrasound's done unless it's approved by the trauma attending or the ED attending, because you need to use it correctly. And we found that we were just not using it right. So that turns out not to be so great. And there's a parallel paper in here on abstract number 12 by Holmes that looks at kids, and it's a similar thing with children. So in children, it turns out not to be terribly helpful. It's specific, not sensitive, and often doesn't change what we do. So ultrasound is fun, but it doesn't necessarily help us. Now, the last paper I want to get into, I think it's the last one, second to last one, looks at the concept of Nexus. So those of us that practice in the United States use Nexus all the time for cervical spine rule-outs. Do they have the 5 Nexus, you go through your list of things, distracting injuries, and are they altered, or are they intoxicated, or are they focal, or do they have central, all the things that you know. Are they tender in the midline when you palpate them? We do the Nexus stuff. But the one part of Nexus that's been bandied about for quite some time as far as whether it makes a difference or not is this concept of distracting injury. Now, when Nexus initially came out, what they did is like, well, what is distracting injury? And on purpose, the authors didn't define it. They didn't say it's this but not this. They basically said, you know it when you see it. And what they did later to confirm that is they got a bunch of people together in studies they did subsequently and said, do you think this is a distracting injury? Dr. A and Nurse B, do you think this is a distracting injury? And intern C, do you think this is a distracting injury? And what they found is that we do tend to agree with each other on what we would consider to be a distracting injury. The question is that an important component of Nexus? And I think a lot of people over time in practicing kind of found that to be something that just was kind of annoying. is that big laceration? It didn't seem to change anything. If somebody really had a cervical spine fracture or cervical spine injury, you often found it even in the presence of somebody with an amputation, or they would still have something else on your nexus that helped you as far as tenderness in the midline or neurologic findings or something. So what they did in this particular study, it's a wonderfully, wonderfully done study. They took people who had decent GCSs. It had to be 14 or 15. So it had to be normal GCS. They went down as low as 14. What they did is they did basically pretty much Nexus. They examined the neck. So if the neck was tender in the midline, you got put back in a collar. Done. They did Nexus without distracting injuries. They basically did pretty much everything in Nexus, but they didn't look at distracting injuries specifically. And what they did then is they did CT scans in everyone, which was wonderful. That's what the sort of the strength of this particular study. And then they looked at what might be distracting injuries later. So they looked at, applied it, kind of overlaid it later. So they did everything in Nexus, short of distracting injuries. They imaged everybody, so they would have caught an injury on CT scan, if it's seeable on CT scan, in everybody, if it's there. And then they listed an unbelievable list. Like everyone listening to this tape would agree of all the things in their list of what are distracting injuries. They covered everything, including things like more than 2 rib fractures, which I'm not sure those are bad enough to be distracting, but whatever. They really lowballed this. They covered external fractures or clavicular fractures. They really lowballed this to include everything that could possibly be a distracting injury. And then they looked at what happened. So first of all, how many people in this study, which is a pretty significant study, almost 3,000 people, how many people ended up with a fracture that was important, a C-spine injury that was important, and how many people had a distracting injury? And did that distracting injury make a difference? So what they found basically is, again, everybody got a CT C-spine and a clinical evaluation. They found that your clinical sensitivity was about 89%, but when they crunched the numbers, and this 7.6% of people had a positive C-spine CT, when they crunched the numbers to get a negative predictive value, they found that your clinical exam, without the distracting injuries part, had a 99% negative predictive value. There was one injury that was missed, and it wasn't an injury that needed to have anything surgically done. So it was basically a fracture with no neurologic outcomes. So it turned out, or did need to be surgically taken care of, but no neurologic outcomes. The bottom line is Nexus. In the Nexus list, distracting injuries adds very, very little. So it is something that you could very reasonably drop out of your Nexus. And I know that in our trauma institution, quite a few of our trauma surgeons basically say, I don't even care. I don't even care. It's not even anything I factor in. If they're tender in the midline, if they're neurologically, impaired, if they're, drinking, if they're altered, I care about that. I don't care about that distracting injury. I'm going to image them otherwise. So it's interesting. I think that's turned out to be fascinating. And then the last study that we're going to talk about in this sort of trauma potpourri of things that we're going through in the last couple of years is PCARN. And what can we do about imaging children? So we know that kids that are traumatized who might have an intra-abdominal injury, imaging that we tend to do is a CT scan. It really gives us kind of the most amount of information, at least on the solid organs and free fluid, blushes and bleeding and that sort of thing. It's very helpful to do that, and more helpful than ultrasound, which we just talked about. But we don't really want to image kids. We don't want to radiate children. And is there some sort of PCARN equivalent rule? We have the PCARN head injury stuff for kids. We can use that to decide which kids need to be scanned or not. Is there an equivalent for belly scans in kids that might have trauma? They derived this particular rule that they haven't, or decision instrument that they haven't kind of put out there yet, but it's probably going to be part of our lexicon soon. They derived this on 12,000 children. And the criteria you had to have, and basically all of these, no evidence of a seatbelt trauma or intra-abdominal or abdominal wall injury. So nothing when you look. GCS that's good, 14 or 15. No tenderness on exam. No evidence of thoracic wall trauma. No complaints of abdominal pain. No decreased bowel sound, or breath sound, so no evidence of like a pneumo. And no vomiting. And again, that's a lot of no's, right? There are a lot of kids that aren't going to fit this. But what they did find is that turned out to be a pretty decent rule. And when they tried to validate that in almost 6,000 kids, it was 99% sensitive. It turned out to be pretty darn good. All right, so we've summarized all this stuff with sort of the update on trauma. The key points to sort of summarize this particular half hour we've had together. First of all, when it comes to head injuries, do really good prehospital care. Honestly, when it comes to anything, do good prehospital care. Don't let them be hypotensive. Don't let them be hypoxic. Don't let them be hypercarbic, and don't blow them down too much. So that makes some sense. TXA and traumatic brain injury is controversial. Whether you really believe it helps sort of the Goldilocks mild to moderate kind of version of head injury, it's not entirely clear, and I don't think everybody's on that bandwagon by any stretch. Basically, prophylactic hypothermia, or trying to get somebody with a brain injury cold, that doesn't seem to help, so that's not particularly helpful. Transfusing patients, if you use older cells versus younger cells, as someone who's older, I like the fact the olders do just fine. So older cells are fine. As long as they're approved by the blood bank, they're good to go. Arginine Vasopressin may have some role in trauma in the future. We just have a pilot study right now that looks at whether that's helpful or not. It may help in blood volume of what we use as far as transfusions, but we'll see. Keep an ear out for that one. Hypotensive resuscitation is probably a best practice. So don't get people normotensive, get them to the organ perfusion level, and you're good to go. Plasma first is a resuscitation fluid. Not so clear about that. Again, keep an eye on that one. That one may be in the pre-hospital setting. If there's long transport time, something that might be useful. Definitely consider using a Bougie as part of your best practice first approach airway, no matter whether you use a videoscope or direct laryngoscope, you name it, it's probably a best practice. Rib fractures in older people don't necessarily need to keep them in the hospital if it's the sole injury and they otherwise have things that are fine at home. EFAST, pretty specific, not terribly sensitive, often doesn't change practice, so it's something to be used quite carefully and deliberately when you're doing resuscitation. Same thing with kids. When it comes to the C-spine, distracting injuries may be something that's overblown and we don't necessarily need to consider, at least in the Nexus criteria. So that person that has a big lac or fracture, that may not be enough distraction to distract you from actually a C-spine injury, so that's kind of helpful. And there's a P-CARN decision rule for imaging children with possible abdominal trauma that's actually now out. That's something that we probably should be using in kids. And again, not a lot of kids will fall into that group that applies to, but any kid that we don't have to image is wonderful. So consider using that. Thanks a lot, and that was trauma.